I'm going to talk about cholangiocarcinoma. First of all, some points worth mentioning about cholangiocarcinoma. It represents the second most common primary liver cancer. It is an aggressive tumor with poor prognosis. Data is scarce due to low incidence. Most tumors are unresectable at presentation. Chemotherapy and radiation are ineffective. The best results are observed in very few carefully selected patients with transplantation or resection coupled with chemoradiation, although 5-year survival rates are still low. Cholangiocarcinoma is a largely heterogeneous group of tumors arising from ductal epithelium, mostly dermoplastic, with many subtypes. Can be classified as extrahepatic, with perihilar disease about 50% and distal disease about 40%, both with stable incidence, and intrahepatic about 10%, with increased incidence over the last decades. Also, there is a mixed type, hepatocellular cholangiocellular carcinoma, less than 1%. Intrahepatic is genotypically different from the rest of cholangiocarcinomas. Morphologically, can be classified as mass-forming and periductal infiltrating type with a worse prognosis, intraductal superficial spreading with the best prognosis, and undefined subtypes. Periductal infiltrating type is the most common from the perihilar tumors. Jaundice is the most common symptom. So, curative resection is the gold standard therapy, but only few patients can be candidates. So the question is, can interventional oncology help cholangiocarcinoma patients? And if so, how and when? All these answers will be addressed at this presentation. As we all know, there are new treatment options which are percutaneous, such as ablation, electroporation, biliary drainage or stenting, portal vein embolization, and endovascular, TACE with C-TACE, blunt embolization, and DCBs, and TAIR, radioembolization. Amongst the few data available, there is a study from Sulen, Rilling et al. With 62 patients treated with chemoembolizations. Median survival was 16 months from first chemoembolization. Furthermore, Thomas Vogel from Frankfurt, Germany, has shown in the biggest series of 115 patients, median survival 13 months and no difference between regimes used. A quick look to our center results. In our retrospective study, which were presented in WCIO a year ago, with 42 patients treated with 125 chemoembolizations. Almost half of the patients had stable disease, mean overall survival 15.9 months. But the point is that 5 patients who became candidates and underwent hepatectomy or ablation, they had mean overall survival 39 months. There are 3 types based on anatomical location. Distal, which is located in the bile duct from the ampulla of Vater until the origin of cystic duct. From there begins perihilar, which extends the second-degree bile ducts, and from there we have intrahepatic type. In the image, we see a typical perihilar cholangiocarcinoma, and this is a post-drainage image. So now to look at our first patient, who is a case of distal cholangiocarcinoma. Interestingly, interventional oncology has the least to offer these patients, and yet there are still things that can be done. Our patient, 59-year-old woman, underwent palliative surgery in August 2004, followed by 2 months chemotherapy. 4 months after the surgery, she came to our department with total bilirubin 11.2, and in the cholangiography, I saw this image with a plastic stent placed at surgery, which obviously no longer worked. So, what do you propose to do here? Can we go to the biliary angioplasty and leave the plastic stent there? I think if we leave the plastic stent there, we increase the possibilities for cholangiitis. So we have to remove the plastic stent, but it is very difficult, cannot be removed endoscopically because it's not in duodenum, but it's in jejunum. So the options, biliary stenting with removal of plastic stent, if we can, drainage and stenting later, or drainage and wait. I chose drainage and wait. The patient went home with a biliary catheter, and 4 weeks later she came back and the plastic stent had immigrated. So I went on to the biliary angioplasty, putting the proximal tip of the stent in common hepatic duct. Our patient refused to continue chemotherapy. So 6 months later, she came with intrahepatic hypovascular lesions, small, in both lobes, and CA99 of 78. So I performed the first chemoembolization in July 2005. What we usually use in chemoembolization is mitomycin, 8 to 10 milligram, and cisplatin from 40 to 100 milligram, and lipiodol, 4 to 6, 7 ml, and microspheres, 100 to 300, or 300 to 500. 7 months later, she came back with total bilirubin 12.7, and she underwent the second biliary drainage, and 2 months later, the second biliary stent-in-stent angioplasty. And again, the proximal tip of the stent was placed in common hepatic duct. So in May and October of 2006, she underwent second and third chemoembolization. In March and July 2007, fourth and fifth chemoembolization, fifth.
Can I ask a question? When you're chemoembolizing these people who've had the biliary interventions in the stents, what's your antibiotic prophylaxis? I forgot to ask you earlier when we went through.
Normally, we said these patients to take antibiotics 2 days before they came, and that's all. So they continue to have antibiotics when they go home.
Okay. What do you give them? Do you know?
Cephalosporin.
Okay. Thank you.
And we are now in October 2007, and I performed the 6th chemoembolization. I have to say, our patient had a good quality of life for almost 3 years now. So, a month later, in November 2007, She came back with bilirubin 11.3, and she underwent the third biliary drainage, and 1 month later, the third biliary stent in stent angioplasty, and this time, the proximal tip of stent was placed in the right hepatic duct. In March and April 2008, she underwent the 7th and 8th chemoembolization. We can clearly see now intrahepatic hypervascular lesions, and it is important to notice that 1 month after the 8th chemoembolization, for the first time, CA99 level increased. In June and August 2008, she underwent the 9th and 10th chemoembolization, both in left lobe. So, in conclusion, our patient with distal cholangiocarcinoma came to our department with biliary obstruction after surgery and chemotherapy. She underwent 3 biliary drainages, 3 biliary stent-in-stent angioplasties, and 10 chemoembolizations, while she refused to continue chemotherapy. These interventional oncology procedures prolonged her overall survival, as she had no other treatment options available outside interventional oncology. She had an overall survival of 49 months from the first interventional oncology procedure, with a good quality of life. So,
any questions about that case before going to the second one? Yep. Yeah, please come to the microphone.
What is your regime? What is the difference of the time from one treatment with conventional chemoembolization to the second or third and so on?
You mean in the study of from Vogel?
I mean, is it 6 weeks after the first chemoembolization when you make the next chemoembolization? Is that the time between?
Yes. Yes.
Okay. And the question, and you mix the mitomycin C with
cisplatin? Yes.
Okay.
Yes.
And another question, if you use
and lapiodol.
And particles also?
No. First drugs with lipiodol, and then embospheres.
Okay. And I'm wondering that so much vessels are still patent after 10 embolizations, although you use the particles.
Yes, we can see here the right hepatic artery in the beginning, in the first chemoembolization, and after 10 chemoembolization. We can see the right hepatic artery so thin we cannot recognize almost. That's from repetitive chemoembolizations. You're right. But with this chemoembolization, the patient had 49 months survival.
And another question is, how many particles do you use?
What do you mean, how many?
Is it the whole vial, or is
No.
until there is no vessel anymore?
No. It depends every time on what you see in the image. You see the flow, and it depends always.
So what's your, John, what's your embolization endpoint with the particles? Are you going till stasis, or are you going till you don't see tumor enhancement?
Depends on if I want to embolize this patient next month, I go for before stasis. If not, I go till stasis.
Okay.
Thank you.
Thank you for the questions.
So our next patient is a case of perihilar cholangiocarcinoma. Perihilar patients are the best candidates for transplantation, although the recurrence rates are still high. Our patient, 53-year-old, with advanced hepatitis B-related cirrhosis with ascites, alpha-fetoprotein 16,000, CA 99-176. Biopsy showed mixed hepatocellular cholangiocarcinoma. In the MRI imaging, we see a mass in the left lobe, about 6.5 centimeters, which caused obstruction and dilatation of the left bile duct. The patient refused transplantation and surgery. So what options we have? Chemotherapy, little to offer. Portal vein embolization, or chemoembolization, or radioembolization. We chose chemoembolization, super selective in the left lobe. And then 2 months later, the patient came back with total bilirubin 13.7. We can see the dilatation to the right and the left bile duct. So I performed the biliary angioplasty of the right hepatic and common hepatic duct. Few weeks later, CT image, we can see lipiodol from previous chemoembolization. The bilirubin levels decreased, but the patient refused our suggestion for a second chemoembolization, and he started sorafenib. After 2 months, he came back with bilirubin 11.2. And I performed the second biliary stent-in-stent angioplasty, this time of right hepatic duct, common hepatic duct, and common bile duct. And the patient refused our suggestion again for second chemoembolization. And so, 5 months later, he underwent an ERCP in another city from a gastroenterologist who removed downwards the stents I placed and partially destroyed them. Furthermore, he left a piece of white wire and a plastic stent. More details here.
They were helping you.
Yes. But the question is, what can we do now? Again, the first what we did is remove the plastic stent by ERCP, and on the same day, I performed biliary drainage, and 2 days later, third biliary stent-in-stent angioplasty. Our patient with perihilar cholangiocarcinoma underwent 1 chemoembolization, 1 biliary drainage, and 3 biliary stent-in-stent angioplasties, and sorafenib, and had an overall survival of 14 months from first chemoembolization. Our next patient is the intrahepatic solitary cholangiocarcinoma, 62-year-old woman with a large tumor throughout the left lobe. What are the options? Surgery? I think it's reasonable. Chemotherapy, little to offer. TACE or TAIR, or TACE or TAIR before surgery. Yes? Before surgery. Okay. We chose TACE before resection. And this is the superselective chemoembolization, left lobe. And this is the next day CT. We can see lipiodol in left lobe. 1 month later, second superselective chemoembolization, left lobe. This is the next day CT. And 1 month later, the patient underwent left hepatectomy, followed by chemotherapy. She was free of disease for almost 2 years. So in August 2014, she came back with 2 intrahepatic lesions in the rest of the liver, 1 close to the heart and 1 peripheral. What do we do now? Surgery? I don't think so. Chemotherapy? Question. TACE or TAE? Already been done. Ablation? I would say yes. Or electroporation? Maybe the same. We chose microwave ablation for both lesions on the same day. These are the images. This is follow-up next month. And 6 months later, she developed new intrahepatic lesions, and we decided to continue chemotherapy. 4 months later, she had progressive disease, and this is the MRI imaging from November 2015. So, our patient with intrahepatic solitary cholangiocarcinoma underwent 2 chemoembolizations, left hepatectomy, 2 microwave ablations, plus chemotherapy, and had an overall survival of 43 months.
I think that's a great example of that sort of using the liver-directed therapy as a test of time before you take someone to surgery with this bad tumor. Because, if you take them to surgery and they get recurrent, they have occult disease and whatever left over, and they have new lesions, in the first follow-up scan, they're not going to do very well. So it'd be nice, sometimes we're doing TACE or Y90 and watching the tumor biology for a couple months before we send someone to the operating room. So I think that's a good approach.
So my last case, and maybe my most exciting. This is a 38-year-old man with these symptoms, and with this CT image in September 2014. A huge central tumor in both lobes and maybe in all segments. Alpha fetoprotein 588 and CA99 175. What shocked us all was a CT image the patient brought us from 4 years prior, when he was misdiagnosed as hemangioma. With these markers, with these tumor markers, we thought it is a mixed tumor, but the biopsy we performed showed only cholangiocarcinoma. So we have this large cholangiocarcinoma. What are the treatment options? Resection, chemotherapy, radiation, ablation, or embolization. Resection is too big. Chemotherapy, little to offer. Radiation, the same. Ablation, too big. TACE or TAE. What do you say? TACE or TAE? TAE. Okay, we chose TACE. This is the hepatic angiography. We can see large left gastric artery supplying the left lobe and the hypervascularity of the tumor. So in early October of 2014, the patient underwent the first chemoembolization, super selective in the left lobe. This is the next day CT. At the end of the same month, second chemoembolization in the right lobe. This is the next day CT. In comparison, 2 months, we saw partial response. So I went on to third chemoembolization in December 2014, super selective in both lobes, and we can see the next day CT. And in January, fourth chemoembolization in both lobes, and the next day CT. And again, in comparison, CT image from a few months prior show us how the tumor has downsized and the tumor markers have dropped. So I went on to the fifth and sixth super selective chemoembolizations in February and April 2015. And our patient, after 6 super selective chemoembolizations, we can see in the images above how the tumor has downsized, and in the images below that the hypervascularity of the tumor has almost disappeared. So, what do we do now? What are the treatment options now? TACE or TAIR again, chemotherapy, ablation, too-big, or resection. We chose resection. So, in June 2015, the patient underwent an extended right hepatectomy, segments 1, 4 through 8, with cholecystectomy and IVC, right adrenal gland, and diaphragm patch resection. Resection margin-free of malignancy, presence of invasion of the right adrenal gland. No evidence of vena cava or diaphragm invasion. The patient received chemotherapy after surgery, and in the follow-up, 9 months later, in CT, we saw a suspicious lesion, and in MRI imaging in early April, we saw a residual tumor. Again, what are the treatment options? Resection, already been done. Chemotherapy, received already. TACE or TAIR. We have very small liver now. Ablation in question, and electroporation. What's your opinion? Ablation or electroporation? The residual tumor is very close to the surgical margins. So, and a tissue very close. I chose electroporation for these reasons. And this is a patient underwent electroporation, and this is the CT follow-up for the next 6 months. Show us response, good response. And this is MRI images until last week. The last image is from last week. Show us complete response, and the tumor markers have dropped. So, this is a good example showing the importance of multidisciplinary approach. Our patient with huge central cholangiocarcinoma underwent 6 superselective chemoembolization, an extended right hepatectomy, chemotherapy, and electroporation, and he is 3 years after the first chemoembolization, now in very good clinical condition. So, thank you very much.